This is Dr. Jeff Leggett, and today I'll be discussing common pediatric musculoskeletal injuries. Today's presentation is brought to you by CHAMP, which stands for the Consortium for Health and Military Performance, whose education arm is called the Human Performance Resource Center, and the URLs are located down below. What are the risk factors for musculoskeletal injuries? They include things that are intrinsic and extrinsic, and those are often in competition with each other. Intrinsic risk factors are those that are non-modifiable, such as your gender, or extrinsic risk factors are those that are modifiable, such as equipment. So what is the largest extrinsic or modifiable risk factor? That would be the training load. Unfortunately, the epidemiology for musculoskeletal injuries in children and adolescents is very poor. What we do know, though, is that the epidemic proportion of injuries we are seeing are usually due to adult training regimes. And we know that growth is a unique site for injuries because it has increased susceptibility to repetitive microtrauma. Likewise, we know that bone grows faster than a tendon, so there's a relative muscle-tendon imbalance during growth. I'd like to leave you with at least one thing, if you can only remember one from this presentation, is that athletes who complaining of pain generally have something going on. And in the adolescent athlete, this may not always be musculoskeletal, it may be some sort of behavioral or psychological issue going on. So remember, young athletes who complain of pain generally have something going on and warrant attention. What are some of the unique anatomy of the growth cartilage? Our growth plate is located here, and below that is the epiphysis of the articular cartilage. Secondary ossification centers where tendons insert are called apophysis. Here's a prototypical case of a 14-year-old male basketball player who has increasing knee pain, and the practitioner decided to get the following x-rays. This gentleman's diagnosis is Osgood-Schlatter disease. It is the most common overuse injury that we've seen in young athletes, and it results from a traction apophysitis. It's usually seen in running and jumping sports, and coincidentally noticed during rapid periods of growth. Some of the clinical features are, again, a young athlete who will complain of a painful enlargement at their tibial tuberosity, and pain is usually always worse with activity. On physical exam, again, they'll have that enlargement, and the tibial tubercle will be tender. And they may have a tight extensor mechanism, but remember, this is because the bone is growing faster than the muscle and tendon. If you do image, you may see that fragmentation that we saw in the previous x-ray. What is the treatment for this prototypical adolescent overuse injury? Really, it's reassurance, letting the patient know and the family know that no untoward event has happened. We modify the activity to pain. If there is no pain, then the athlete can play. If there is a little bit of pain, but they're able to perform at a high level, then they can go ahead and compete. And likewise, if the pain is too much, then they need to sit out that practice, that game. We often recommend extensor flexibility, although to be quite honest, it's just going to take time for that muscle tendon to grow in length to what the bone has already grown. We do recommend a patellar tendon strap, and what you see here is actually called a dual action strap, where there is a strap at the patellar tendon and a strap at the quadricep tendon. This is a form of a counterforce brace, and the way a counterforce brace works is that the force is distributed over a wider area as opposed to always coming right at that tibial tubercle. And so this is patellar tendon strapping. You can either do a single strap or you can do the dual action strap that you see here. And on the rare occasions we may temporarily mobilize the patient, but again, that is quite rare. It is important to know that there is a differential diagnosis for Osgood-Schlatter disease. One of the things to be aware of is the same condition can happen just a little bit superior from this tibial tubercle that is common at the Osgood-Schlatter. At the inferior pole of the patella, you can have something called Sinding-Larsen-Johansson disease. It's really the same exact entity as Osgood-Schlatter. There can be a benign tumor called an osteochondroma. It is important to be aware that patellas can be both bipartite and tripartite, and this is distinguished from a fracture in that this is not an acute injury. There's no acute swelling, although they could be symptomatic at the soft tissue interface between these two separate parts of the patella. Adolescents do get patellofemoral pain syndrome, but remember that that is a diagnosis of exclusion. For more information on patellofemoral pain syndrome, you can refer to one of our previous podcasts. We'll discuss this entity in more detail in the subsequent slides, and if there's an acute injury, you can actually avulse a piece of the tibiotubercle off and have an avulsion fracture. What's unknown is, does Osgood-Schlatter predispose you to a tibiotubercle avulsion fracture? And one would think that that is possible, but again, remember I said that epidemiology is poor on here. But again, this will be a history that there's trauma, there'll be swelling, and the athlete will have trouble walking at all, and this will not be a subtle diagnosis. I mentioned the term osteochondritis dissecans before, and that can be confused with these three other terms: osteochondrosis, osteochondritis dissecans, and osteochondral defects. And here's the definition of those. Simply put, an osteochondrosis is a disease of the ossification center only in skeleton immature, so folks who have physes still present. While an osteochondral defect is a laundry basket term, or I should say a basket term, that would include any subchondral bone and articular cartilage abnormality that has multiple etiologies, of which an osteochondritis dissecans is a form of an osteochondral defect. So this is a specific type of osteochondral defect, where an osteochondritis dissecans is an inflammatory condition of subchondral bone and its overlying cartilage. It can happen both in the skeletally immature and the mature. When it happens in the skeletally immature, there is a chance for healing. Unfortunately, when it happens in the mature skeleton, healing is less likely. So again, it's important to know the difference between these three terms. This is a subcategory of this. So, osteochondrosis, again, that affects immature skeletons at ossification centers, and it is caused by a variety of different factors, and we don't know which one happens, and they're probably multifactorial, to be quite honest with you. So, they can be divided in the upper extremity and lower extremity. Anywhere you have a secondary ossification center is a potential site for an osteochondrosis. In the upper extremity, the elbow is the most common sites, and we'll talk about this in a few subsequent slides. It is important to know in the back, in the thoracic vertebrae, at the anterior portions of the thoracic vertebrae, is a classic an osteochondrosis called Schumann-Rehn's disease, and it is clinically defined by at least 3 contiguous thoracic vertebrae that show signs of osteochondrosis, and you have an increased kyphosis. The ones that we are just discussed in the lower extremity is your typical tibiotubercle epiphysis or Osgood-Schlatter. We mentioned its corollary that is a little bit cephalad at the inferior pole of the patella called Cindy-Larsen-Johansson syndrome. In the hip, at the femoral head epiphysis, is something called Legg-Calperthy disease, which we'll talk about in a little bit. And the heel and the foot can have quite a few osteochondroses. One of the more common ones is something called Seaver's disease, which is a calcaneal epiphysis. And then there is one in the navicular bone, and then one in the secondary metatarsal head. But the important salient feature is any place that there's a secondary ossification center can be a site of an osteochondrosis, and it's important to keep those in mind. So we mentioned the upper extremity osteochondrosis. So this would be a typical case for this, where you have a 12-year-old pitcher who has increasing pain at the medial side of his elbow on his pitching arm. And so his diagnosis would aptly be called Little League elbow. And so Little League elbow is caused by either a compression on the lateral aspect of the elbow and then a subsequent stretch on the medial side of the elbow in the cocking phase, and then when they follow through on their pitch, it's the opposite. So this is the cocking phase, and as they cock their arm back, as you see here, they compress the lateral aspect of the elbow while they're stretching the medial side. And so there is tension pushed on this portion of the medial elbow that's being stretched, and there's compression on these portions of the lateral elbow. On the medial side, where the stretch happens in the cocking phase, you can have just an epiphysitis or an avulsion of the medial epicondyle. And then on the lateral side, where you have your compression, you can have osteochondritis dissecans. And remember, that is an inflammatory condition of the subchondral bone in the articular cartilage. So you have compression of the capitellum here. This is an example of a medial side epiphysitis, and this is an example of an osteochondritis dissecans here. And the key in this is recognizing that this is a potential and actually preventing it. And the way we prevent it is by pitching programs. And there should be a limit in the amount of pitches both in practice and games that these young athletes do. And although some folks adhere to that limit, they then put these athletes who are subsequently probably the better athletes either on third base or on shortstop, and they're trying to throw to first base, and they are not actually giving their arm a rest. And so really, this pitching program should be a throwing program where you limit the amount of throws that a young athletes get. So again, pitching program or prevention is the best thing. If they do develop this condition, then allowing them to rest and strict adherence to the amount of throws that they do. If there's concern, then you can always consult your sports medicine or your pediatric orthopedic for help with this condition. Okay, so moving on to the female athlete. So you have a 14-year-old female gymnast who complains of midline low back pain. If you remember back to those osteochondritis slides, we had some diseases that happen on the spine too. So is this one of those conditions? Actually, not quite. So the one I referred to before was called Schumacher's disease, and that was in the thoracic vertebrae. This is in the lumbar vertebrae. And here we have an injury of the pars intra-articularis. And this lateral or oblique projection of the lumbar vertebrae is called the Scotty dog. And if you will bear with me, this is the ear of the Scotty dog, this is the nose of the Scotty dog, the pedicle is the eye, and then here's the feet. And if you see a collar on the Scotty dog, that would refer to an injury of the pars intra-articularis. And this is what this young lady was suffering from, a disease called spondylolysis. So the clinical description for spondylolysis is the most frequent anatomic lesion in the adolescent athlete with low back pain. And again, it's a mechanical injury of the pars intra-articularis, and most often happens at L5. So some of the clinical features are an insidious onset, worse with activity, and particularly in hyperextension, and the pain can radiate to the buttocks. And so what athletes are prone to this, again, with this hyperextension? Well, the gymnasts that we mentioned, also divers can get this, and then offensive linemen are also apt to get spondylolysis for numerous different reasons. One is they are being constantly bent back as they're blocking, and then these athletes are also trying to lift probably more weights than they should, and they arch their back while they're trying to do military press or when they're doing squats. And so again, gymnasts, divers, and offensive linemen are people that we worry about with this. There are not a lot of great physical exam maneuvers, but the single leg hyperextension test, which we'll describe in a little bit, is one of the findings you may find. And you may find some poor hamstring flexibility, but again, remember that the muscle tendon elements lag in their growth compared to bone, and so it may just be a manifestation of growth. And the important thing is to image when you're considering this. And we discussed the collar on the Scotty dog, and we'll show that a little bit more. And then really you're probably going to need to get some advanced imaging, and we'll talk about bone scan with a specific type of bone scan called a SPECT scan, single photon emission computerized tomography imaging, and or MRI. Here is the single leg hyperextension test, or the Stork test. Unfortunately, a systematic review found that it was a poor predictor of the condition, and it really should not be used as a diagnostic tool, although it can complement your clinical suspicion. And so there really are no good physical exam techniques, so really the history is the key, and if you consider it, you need to rule out that this condition is present. And so this is in an x-ray, which is of the cartoon that we shot earlier that started our case, and this is the collar on the Scotty dog that you see right here, and here's the ears, here's the nose, here's the feet, and here's a collar on that Scotty dog. In the level above, you do not see that collar, and so this would be an injury or a stress fracture of the pars intra-articularis of the L5 vertebrae. And so you won't see that often on your plain films, and so bone scan is often used. And this is just a regular bone scan. And on the AAP view, you don't see much activity. On the PA view, when you turn the patient around, maybe some activity here. But this same patient went on to get what was called a SPECT scan, single photon emission computerized tomography scan, and you can clearly see some increased uptake here that is abnormal compared to the other vertebrae, and maybe a little bit of increase at the contralateral pars intraarticularis. And so this is much more sensitive and specific than just a regular bone scan. And then for those athletes that you move to get an MRI, it's actually pretty evident of the swelling here. You actually can see a fracture line. You can see a fracture line here compared to here too. And so that's pretty evident if you go on to get an MRI. The other advantage of MRI is you could see disc pathology or other problems too. So here's some other terms that can be confusing. I'd like to define these a little bit more. So we've been talking about spondylolysis, but you may have seen in reports something called spondylosis, and you may have also heard about spondylolisthesis. So what are those? Well, spondylolysis, we've just referred to, is the injury of the pars intraarticularis, and in the adolescent athlete, it's usually a stress fracture. If you have bilateral spondylolyses, then the vertebrae may slip, and it usually slips forward. If that happens, that's called a spondylolisthesis, and we'll talk about that a little bit more. And this one's actually a grade 3, but we'll talk about those gradings in the subsequent slides. And then simply spondylosis is just a disease of spine. So lysis is actually the fracture of the pars intraarticularis. If you have a bilateral spondylolysis, it can slip, and it's called a spondylolisthesis, and it's either an anterior or a posterior spondylolisthesis. And a disease of spine is just called a spondylosis. We mentioned the spondylolisthesis before, and there's a grading criteria, and this is your normal here. A grade 1 is less than 25% of slippage. A grade 2 is 50%, up to 50% slippage. A grade 3 is 75% slippage, and a grade 4 is 100% slippage. And so the treatment depends on if the lesion is actually active and the degree of slippage. And the activity of the lesion you can actually see via bone scan, and if you got a bone scan and the area did not light up, then it would not be an active lesion. Our MRI could tell you that too if there was inflammation around there. And again, the degree of slippage. Now you won't see the degree of slippage on a bone scan. You'll need plain films to do that, and or an MRI. And so for the primary care provider, if you had a grade 1 slippage, so 25% or less, and it was not active, they really need no treatment. All others really need to be referred on to sports medicine or orthopedics for bracing and or possible surgical intervention. So let's see what the answer is for this case. So we have a 14-year-old female gymnast who complains of midline low back pain that is unchanged with her hyperextension test but is relieved with rest. She has had this pain for greater than a month. Her physical exam is normal, except she has decreased extension, although this does not cause her any pain. You do x-rays, which include an AP, a lateral, and an oblique x-ray, and they are negative. You do not see that Scotty dog. What is your next test that is indicated? Give you a few seconds to take a look at that. Other choices here, that would be a bone scan. And if you did get a bone scan, I would recommend you get a SPECT scan. But should you get an MRI? Well, that really depends on your institution and depends how quickly you can get the test and what your consultants want. I have started gravitating to use an MRI more, but there's certainly nothing wrong with getting a SPECT scan or a bone scan. So let's shift gears and now talk about a LIMP. So what is the definition of a LIMP? It's an asymmetric deviation from the normal gait pattern. Your normal gait pattern, the majority of your time is spent in the stance phase with 60% and then 40% in the swing phase. And so what is a LIMP? A LIMP is when you don't want to be on the stance phase because it's causing pain. So a LIMP causes increased time in your swing phase to avoid bearing weight on that injured extremity. How common is it? Well, one study showed that out of 1,000 visits to a PEDS emergency room, so a specialty emergency room, you had 4 cases out of 1,000 to a peds emergency room. So not super common, but unfortunately there can be quite a bit of morbidity associated with this, and so this is why this is an important entity for us to discuss. And so the differential diagnosis is large, and I don't put this slide up to make anyone memorize you. I do put it up to slightly intimidate you so that I can hopefully give you a better paradigm for diagnosing this. And a better paradigm is making the differential diagnosis by age. So if you just keep a couple things in mind, that it can always be referred pain from the GU or GI system, and no matter what age, if you always kind of think, could this be an infection or could this be a cancer, then you can move on to age-specific diagnoses. And so the younger people, so less than 3, septic hip is the thing that you're worried about mostly. And for the 4 to 10, you can get a reactive synovitis or toxic synovitis, which is more common. And for those that are 11 to 16, you can get a slip capital femoral epiphysis or a SCFE. So again, always think infection, always think cancer, always worry about referred pain. And then younger ages, infection, 4 to 10, toxic synovitis, 11 to 16, slip cap femoral epiphysis. And this is a good way to think about this. So what is the history? When taking a history of a LIMP, is it acute versus chronic? So acute onset makes you worry, again, more likely of infectious etiology and or fractures. And was there trauma? And unfortunately, trauma doesn't always just mean fracture. It actually can be the nidus for an infection. What happens is the children are growing. They have robust blood supply to those joints. There always is a transient amount of bacteria inside of our bloodstream. If they suffer some sort of trauma, even if it's not enough to cause a fracture, blood will increase at that area of injury, and coupled with the transient bacteremia, it can be a setup for a septic hip. And this is a common scenario to happen. So did they have trauma? That may be an indicator that they have a septic hip. Again, is it pain or is it painless? And that toxic, one of our diagnoses, Legg-Calperthy disease, is actually called the painless hip or painless limp. So do they have pain? Are they improving? And if they're younger, maybe they won't walk, but will they crawl? That's helpful. And the following are looking for rheumatologic or neurologic problems. And so is it worse in the morning or evening? That could be rheumatologic and or malignancy. And what is the review system? So again, looking for are they systemically ill? And looking for neurologic problems, what is their birth and what is their family history? So these are the important historical elements when you're dealing with a child with a LIMP. So what are you going to look for on physical exam? And so will they walk on their toes? Will they walk on their heels? And then will they hop? And so somebody that will hop, it's really unlikely that there's anything serious on there. Having the patient run can be helpful. That will disclose some neurologic issues, along with looking for claw feet or cavus feet, and cavus being defined as high arched feet. What is their deep tendon reflex, and is there clonus? And again, that's looking for spinal cord involvement and also looking for spinal movement. We'll talk about this in more detail. And then also remember, referred pain is quite common. So it is not unusual to hear about someone presenting with knee pain. The knee exam was normal and it turned out it was hip pathology the whole time. So if you have a normal knee exam, always consider that it may be hip. And another axiom for musculoskeletal medicine is always consider the joint above and below. And do not forget about referred pain, subsequently skin and GU and abdominal exam. So the hip exam. So it's important to know that the position of the hip that will allow the most volume and the least amount of pressure is flexion, abduction, and external rotation. So if a patient is holding their hip in that way, which is the figure 4 position, that is because there is some sort of inflammation, irritation, or fluid inside the hip, and they are trying to maximize their volume. And subsequently, if they have decreased internal rotation, that usually means there's hip pathology. So we'll be looking for the patient carrying their hip this way, and we'll be looking for decreased internal rotation. And so how do we measure that? So the most sensitive and specific way is to place the patient prone and compare sides. We have them prone, and then we're trying to internally rotate their hips. Sometimes it can be confusing, so another way to do it is called log rolling, and where you have the patient supine and you simply take the foot and you internally rotate it or you externally rotate and see if there's pain. Again, this is more sensitive, although sometimes you can forget which is internal and external rotation. So again, maximal position, decreased internal rotation means some sort of hip pathology. That's true both in the adolescent and in the adult. So further on, the hip exam, you're doing this test to look for hip dysplasia, leg length discrepancy, and in here this would be a patient that had hip dysplasia and the femur slipping farther back because the hip is malformed, and so one leg appears shorter than the other because one knee is taller than the other one, and so that is one way to check for hip dysplasia. The other thing we want you to get in the habit of doing is looking for hip weakness, and this is called the Trendelenburg side, where when you normally stand on one leg, if this on this side the left leg is strong, it will be able to hold the pelvis in neutral. But if the left pelvis is weak here, the pelvis will drop down on the leg that's lifted, and so this is the weak side, even though this side drops down. And so that's indicative of weakness on here. This is the figure 4 test, or the Faber test, which stands for flexion, abduction, and external rotation. And when we examined this patient and we went to move them here, their hip went into obligate external rotation because they had a condition called SCFE, because again that maximized that volume in here. And so this is the exam that we would be trying to do, put them in the Faber to see if there's hip pathology, or do they automatically go there, showing that that's the etiology. So some other tips for examining the hips: if you have a very anxious patient, go ahead and examine in the parent's lap. There's nothing wrong with that. And sometimes what I'll do is I'll take the child and separate them from the parent, have the parent go down the hallway and ask the parent to call for the child. And if the child runs to them, that helps me quite a bit because they're bearing weight, and it makes me less concerned. But a child who just sits there and won't go to their parent makes me worried that their pain is the reason they're not doing that. So you're almost always going to get radiographs for a child who has LIMP. And when you do, you must always get 2 views of suspected area. They need to be orthogonal views or 90-degree views. And this would be an example of this. And so this is a either a PA or an AP view, but this looks normal to me, maybe a little over-penetrated. But then when you get the true lateral view, it's very easy to see the spiral fracture in the tibia that now, in retrospect, is probably right here, although the lateral view showed it. So you always get to get 2 views of an area, and if you get 1 view, that's not acceptable. And in the hip, the way to do that is to get a frog leg lateral view. And so this is an AP view of a patient, and here's lines drawn, and here's arrows, and so this arrow is bigger, and there's probably pathology there, but it's not super obvious. But when we get the lateral view, or the frog leg lateral view, it's very obvious that this looks different than that side. And this is a patient who has SCFE, and we'll go on to that in more detail. In the nonverbal patient, what should you do? Well, you may want to consider getting a screening AP view from the hip to the feet to look for things such as that spiral fracture of the tibia that I showed you earlier. And if you suspect a hip infection, ultrasound is much more sensitive for picking up abnormalities on there. And then if all else is negative, you may want to consider getting a bone scan. But the salient point is you're almost always going to get some sort of imaging with a child who comes in with a LIMP on there. And so if you're suspecting a septic hip, you're probably going to get some blood studies, and here's some other caveats to think about. When you get your CBC, if you have more than 2 cell lines down, you need to always think malignancy. You're probably going to get one of the acute phase reactants, and nowadays C-reactive protein is supplanted sed-rate because it's more sensitive and it rises earlier. And if you do a tap of the hip or an aspiration of the hip, you're going to be sending the joint fluid for analysis, and that is very helpful, but I want you to be aware that unfortunately there is quite a few antibiotics being used, and partial treatment may abscond your results of your joint fluid. And you probably will get blood cultures, but don't rely on them for being that positive. And rarely you may consider some of these other tests. let's talk about some specific conditions a little bit more detail. Remembering the septic arthritis is in that 1 to 3. Transient synovitis is 4 to 10 years of age. Leg calprothes is also in that 4 to 10 years of age. Slip cap femoral epiphysis, or SCFE, is in your 11 to 16 years of age. And we'll also discuss, does growing pains really exist? And so what is toxic synovitis? Well, it's the most common cause of hip pain under 10. Unfortunately, it's a diagnosis of exclusion, so you need to rule out all other conditions. We don't really know what causes it. We think it may be post-viral, and does seem to be a male predominance 2 to 1. Fortunately, the treatment is supportive. There's no specific treatment, but that would go back to the diagnosis of exclusion, the unknown etiology. And there may be some late sequelae of the femoral head, and so some have advocated doing follow-up films on a yearly basis until skeletal maturity. That's certainly not evidence-based at this point, more expert opinion. And so really your big question is differentiating septic arthritis versus toxic synovitis, realizing that the hip is the most common joint to be involved in septic arthritis. Remember, we talked about a history of trauma and or upper respiratory infection because of that transient bacteremia. The common etiologies, bacterial etiologies for septic hip are Staph aureus and strep. Fortunately, H. flu is rare now due to our Hib vaccine. And so this study done by Coker in 2004 found that these were the parameters were more likely in a septic hip. And so that gave them a diagnostic tool that if the white count was over 12,000, if they had a fever, and they defined fever as 37.5, realizing that 38 is actually is 100.4, and so this was really right at 100, and a slightly elevated SED rate mandated that they would aspirate the hip on there. And always be wary of the partially treated patient with oral antibiotics. So this may be a helpful little tool for you. So that was toxic synovitis. Again, ruling that out from septic hip was the biggest thing. And then let's move on to the next most common for the 4 to 10 years of age, called leg calprothe disease. And what is leg calprothe disease? Well, it's avascular necrosis of the femoral head, so lack of blood supply to the femoral hip. We don't know the etiology, but for some reason the blood supply is interrupted to the femoral epiphysis. And there is a male predominance, almost a 5 to 1 predominance here, which may lead credence to the fact that toxic synovitis, which remember we had a 2 to 1 male predominance, goes on to cause leg calprothe disease, although we're not quite sure. And there are unfortunately no systemic signs, and this is a painless limp. So remember back in the history I asked you to ask the patient if there's pain or not, and if a 6 or 7-year-old comes in and they're limping but it doesn't cause them pain, then this is really the diagnosis I'm thinking about, and here's the age groups that we already talked about. And so the way to diagnose this is actually via, you can do it with plain films, but most likely you're probably going to get a bone scan. If you do get plain films, it's important to note there's stages in here. And so the first stage is edema, and you can kind of see some swelling at the articular cartilage here, and so that's lifting this up of the synovial membrane and capsule. That's swelling, so that's stage 1. And then right here we're getting necrosis. Actually, this is necrosis right here, and you see resorption, and then as it starts to regenerate, that's the third stage, and so it's starting to grow back on here. And so there are some various stages of leg calprothe disease, and again, you don't have to memorize this. But again, the way to diagnose this is by bone scan, and you're looking for a cold area as opposed to spondylolysis, where you see a hot area, an active area. Remember, this is avascular necrosis, and so there's no blood supply going to this part of the bone as opposed to the normal bone here. And so this is a cold area bone scan, and all of these need to be managed by orthopedics or pediatric ortho. And so what is this condition where we see the femoral epiphysis actually looks like it slips off the femur? Well, this is called slip capital femoral epiphysis, or SCFE. And again, it's slippage of the proximal femoral epiphysis on the femoral neck through the physis plate. So here's the femoral neck, here's the proximal femoral epiphysis, and it slips off. And it occurs during the adolescent growth spurt, and it is the most common disorder for the adolescent. So not super common, but again, unfortunately, the morbidity is high. and there's a delay in diagnosis of up to 10 months, and so we want to minimize that, which is why we're discussing it. And again, unfortunately, 50% are usually missed on the initial exam, but you won't miss this because you listen to this presentation. And it's important to know that this does happen bilaterally, and there does seem to be a body habitus, either the obese or the tall, thin adolescent, probably due to hormones and our growth. And so SCFE can be defined as stable versus unstable, and essentially the patient that walks into you will be stable, and the one who needs to come in on crutches is unstable. And so remember this picture I showed you on the exam. When you go to flex their hip, they don't want to do an internal rotation, and they'll obligately go into external rotation when you go into hip flexion. And so you would try to internally rotate it. They wouldn't like that. When you went to flex their hip, this is how their hip would go into. And one caveat is if they complain of quite a bit of pain and they don't want to do any active range of motion, you may not want to go ahead and force them in this flexion until you get your x-rays, because there are cases reports of displacing the epiphysis even further. And you may just want to leave them on the exam table or a gurney and do a cross-table lateral. And so I would do this if they came in on crutches and they didn't want to actively move their hip at all. I would go send them for films right away without trying to do any passive range of motion. And unfortunately, this is an example of normal, where along the femoral neck we draw a line here. There is a portion of the proxofemoral epiphysis that is on both sides of the line. This is a SCFE where it's slipped off, and so you see no portion on the other side of the line. And this, unfortunately, is one that is totally displaced, and this is really a catastrophic condition or catastrophic portion of this disease, and we want to avoid this, which is why if they have limited active range of motion, probably don't want to do much passive range of motion on them. We already mentioned this before, and so when you get your AP view, you can draw these lines on the femoral neck, and there should be a portion on both sides of the line. If there's not, then that is highly suspicious for SCFE. The line is called a Klein's line. And then remember I said you always need two views, AP and the frog leg lateral. In the frog leg lateral, it's pretty easy to see that this is abnormal on there. And all of these are getting referred, and they will all get surgically pinned. And again, remember that it can be bilateral, and maybe both sides will get pinned on there. So do growing pains exist? The answer is yes, but they need to fit this definition. They need to be bilateral. The pain almost always occurs at night, and usually they have no symptoms during the day, and they're very active. And so if it doesn't fit this paradigm, it could be something else, but there is such a thing as growing pains. So to recap for the pediatric LIMP, it's the workup is dictated by exam. Remember your age-specific diagnosis. Always consider infection and cancer. Strongly consider doing some blood work. If you have some of the parameters that are elevated, you're probably going to consider doing a joint aspiration. Almost everybody needs to get a hip x-ray, and the follow-up is key. And finally, decreased internal rotation is a bad thing. So shifting gears, is it okay for children to sit in this position? The answer is yes, it's okay for them to sit in this position. So let's talk about in-toeing. In-toeing really comes from three places. It's either from the femur, from the tibia, or from the foot. And so in the femur, it is anteverted or slightly angled forward, or the internal tibia is has torsion or it's twisted, or the foot is in a C shape. And so this is an example of femoral anteversion, and this is the normal position of the hip. And an anteverted hip is actually rotated, so the greater trochanteric area is actually rotated forward, and the femoral head is rotated backwards. And this is a patient who has bilateral femoral anteversion, and they have exaggerated internal rotation on here. And so this is femoral anteversion, and this is a patient that has internal tibia torsion, and so the tibia is turned inward. This is the normal side, and on this patient right here, this is the, actually both have bilateral internal tibia torsion, although it looks like the right is a little bit more, and so really this portion of the leg is rotated in. One of the ways to differentiate these two is by looking at the patella, and you can see here that both patella are pointed in because the femur itself is internally rotated, whereas the lower leg is internally rotated, and the femur or the patella is pointing out. So patella is pointing out, tibial torsion, patella is pointing to each other, femoral anteversion. And then finally, metatarsus adductus, really in the younger age population, and if this is flexible, and usually it is flexible, this will resolve with time and there's nothing to do. If it's inflexible and you can't bend that back, then they need to see the surgeon. Really, these two conditions, there's nothing to do. It's a normal variant, and if you're uncomfortable with the diagnosis, you can refer on, or you can reassure the parents. Usually they resolve over time, and they subsequently have no problems. Patients that are unable to run or tripping on themselves because of this, those would be ones that you would refer on. But it's important to know that there are 3 different conditions that can cause in-towing. So let's do a little bit of review. Take a look at these x-rays. Which one is abnormal? The one over here is abnormal, and this is a sign of a SCFE. This is your Klein's line here. And then looking at this x-ray, what is this condition called? And it's the painless limp. It's called Calperthes disease, and this is the abnormality right here. This is your AP view. This is your frog leg lateral. Let's look at this question. Which one of the following should raise suspicion of a septic arthritis? And it's an elevated temperature, and remembering the temperature does not have to be 100.4 for a temperature, according to that study that we looked at by Coker. And if your patient had an obligated external rotation of the lower extremity when your hip is flexed, that's suggestive of which condition? That is your SCFE. And finally, the treatment choice for the patient with Osgood-Schlatter is relative rest. If it hurts, don't do it. If it doesn't hurt, then they can proceed in activity. So lastly, I'd like to talk about a couple other entities, so some unique fractures in the skeletal immature, and I want to refer you to the Salter-Harris classification, and this is a mnemonic. And so a type 1 Salter-Harris fracture, the S would stand for straight across the physis, and the A stands for above, where this is the epiphysis, this is the physis, and this is the metaphysis. So in looking at this one, the A is for above the physeal plate. L is lower or below, and actually goes through both, or I should say goes through lower. So the S is straight across, the A is above the physeal plate, the L is low or below it. The T is for 2, and so it goes both at the metaphysis and the epiphysis, and the ER is erasure, or R for rec. So straight across, above, lower, through both, or rect. And so these are 1, 2, 3, 4, and 5. On this patient who has 2 actual fractures, and we'll talk about this one in a little bit, what is this fracture? And I flipped this from that, so that may be a little disorientating, but here's the physeal plate, and so the fracture actually goes through the metaphysis. All right, so this would actually be a type 2 Salter-Harris fracture, and this correlates to that one right there, if you can see that. So it actually goes on the metaphysis, and so this is a type 2. And this fracture right here is the same as this fracture, and we call that a green stick fracture, which holds to a branch that still has vegetation inside of it, and it doesn't break on both sides, and so that's why it's called a green stick. So you have a fracture just on one side. And then this one is called a torus, or a buccal fracture, and if you think of squishing a styrofoam cup, that's a good example of what a torus fracture is. And then fortunately, these can be treated very conservatively, and immobilization is not required, and they do well. Here, anything 3, 4, 5, we worry about the growth plate, and so these probably need to be managed in concert with a sports medicine orthopedic surgeon. And then the final thing I'd like to touch about is things that are unique to the growing athlete, and not just the female. And you may be familiar with something called the female athlete triad, where you had decreased energy, and so there was energy deficiency, and that would cause some menstrual irregularities, and you would have some bone health issues. Well, that term has been replaced by relative energy deficiency in sports, are called REDs. And so no longer is called the female athlete triad because it's not unique to just females. It can happen to male athletes too. And so here's REDs, and here was the old female athlete triad that was just menstrual dysfunction and bone health. We now realize it can do a lot more and affect all organ systems, and that it's not just with females, it's also with males. And so any relative energy deficiency can cause these abnormalities. And these are some of the different parameters that it can injure. Again, their increased injury risk, their performance will decrease, they have muscle strength abnormalities, they don't have enough energy to support their needs, and it can have behavioral health issues, that goes along here. And so I bring this up just so you're aware of this change in the nomenclature of REDs. And then I'd like to just briefly talk about the pre-participation physical exam. And again, it's not to exclude folks, but it's for all to participate as much as they would like. And so our job is to find what activities that they can do well at. And so the job is not to exclude. And it's been likened to finding a needle in a haystack. And what we do know is history is the most important factor, and really not the physical exam, but the history is the most important factor. And so in summary, I want you to be aware of the unique factors in the skeletal immature that can predispose them to certain injuries. And remember that growth sites are an area of injury because they're vulnerable to repeated trauma, and also bone grows faster than muscle and tendon. And we should not be training our adolescents as adults. They have no place in that, and there needs to be subsequent rest to allow them to accommodate. And then finally, remember, sports in childhood are supposed to be fun. And so when it stops being fun is when we start to get injuries. And so I thank you for your attention, and please contact us if you have any questions.